Yes, don't worry. Let me just see if it has gone online now.
Good morning.
Yeah, okay, connected now.
Good morning, everyone.
Hey,
We
guys.
welcome you all to OrthoTV online MISSAB webinar in association with Minimally Invasive Spine Surgeons of Associations of Bharat. This webinar is brought to us by an unrestricted educational grant from Aquila Division of INTAS, the makers of Gabapin NT. So over to today's convener, Dr. Arvind Kulkarni, to take over the proceedings.
Hi, good morning, everybody. Welcome to another episode of Minimal Access Spine Surgery. So we have a big breakfast platter this morning. So it is 1.5 times more compared to the last month's breakfast platter. So we have extended it to 90 minutes based on the feedback that we got from senior members of the association. I'll not be taking much time. I will straight away introduce Dr. Amit Jala, who actually doesn't need any introduction. He's our vice president of our society and one of the key founder members. He'll be coordinating. He'll be the academic chef of the morning. Thank you, Amit. Please go ahead.
Amit, unmute.
I welcome all of you to this second MISSAB tutorial. And these MISSAB tutorials are designed so that everyone interested in minimally invasive spine surgery can learn together, right from the experts to the budding newer surgeons who want to continue with minimally invasive spine surgery. And this time we have got again, we have changed our format, which was there last time. And we all know that it's important to read to keep pace with this era of information explosion. And hence, we have first selected 2 journal articles, which will be presented by the MISSAB members. After that, we all know that sharing the experience makes us increase our knowledge. And then we will have case presentations from our 3 of the members. And the last, after reading and sharing the knowledge, we need to incorporate these things in our clinical practice. There is a lot of anxiety in the young surgeons how to incorporate these newer techniques into our clinical practice. And an experienced surgeon, they have a rigidity of the ideas, how to take it forward in their clinical practice. And then we will have a keynote address by one of our senior faculty, Dr. Ajay Krishnan. So we will start straight away with the journal articles, and I would invite Ajay Krishnan and team. From his team, I would invite Dr. Devanand to start with the proceedings with the first journal article. Devanand, please.
Yes, sir. A very good morning to all. I am going to present a journal. This is Rethinking of Surgical Treatment of Lumbar Spondylosis, the anatomic considerations. This study has been conducted in 2 different centers, one from Japan, the other from Boston, USA. So as you all know, the natural history of degenerative spondylosis has been described as progressing through a phase of instability and returning to stability with the progression of degenerative changes into the degenerative cascade. This is initially described by Kirkcaldy-Willis. All of you know this in 1982. Followed by this, Simmons and Matsuganga, they reported that the natural history of degenerative spondylosis, there is no progression of slippage was seen if there is disc space narrowing, spur formation, and facet joint degeneration. So the main aims of this study were to develop a pathological classification based on the natural history and determine how the subtypes of degenerative spondylosis based on this pathological stage, they affect the clinical outcomes of microendoscopic laminotomy. So their hypothesis was the patients in advanced stage of degenerative spondylosis with dynamic instability and preserved disc height have the least favorable results following minimally invasive decompression without fusion. So they have conducted this study it's a retrospective study from January 2009 to 2014. The inclusion criteria were single level degenerative spondylosis at L34 or L45 with evidence associated of lumbar spinal stenosis. They specifically have this criteria of neurogenic claudication or radicular plane, and on cross-sectional imaging of lumbar spine of MRI, they have lumbar spinal stenosis with a failure of conservative management for greater than 3 months. Exclusion criteria were coronal curvature. That means the patient having degenerative scoliosis of greater than 10 degrees. So according to their proposed classification, they have classified according to the disc height and the slippage. If the disc height was less than 1/3, the loss of disc height was less than 1/3, it is classified as early. If the loss of disc height was less than 2/3, they have classified it as advanced. And if it is more than 2/3, they have classified it as end stage. Along with that, they have taken into criteria the amount of slippage. Less than 10% as early, more than 10% as advanced, and dynamic slippage as end stage diseases. So these are the representative MRI images. Stage A is early stage where you have the preserved disc height. Stage B is the advanced stage where there is collapse of disc height with dynamic instability. Stage C is the end stage where there is no dynamic instability and there is a height of disc. So the surgical technique they have employed here is the endoscopic assisted laminotomy, where they have used serial tube dilators of the Medtronic Sophomer, which was developed by lumbar disc herniation through a small incision. And they have performed this tubular decompression of bilateral lateral discs, and they have used the curved Kerrison plunger to preserve the integrity of the facet joint. The materials and methods, they have seen the recovery rate. They have taken the JOA score as the comparative measure. The recovery rate was calculated as 100 into postoperative JOA score minus preoperative JOA score divided by 29, which is the maximum JOA score minus pre-op. And the results were classified as excellent, greater than 75%, good, 50 to 74%, fair, 25 to 49, and less than 25 as poor. The successful treatment, they have classified it as recovery rate more than 25%. And the percentage of slip, as of all of you know, they have calculated the ratio between the anterior-posterior translation of L4 over L5 to the anterior-posterior diameter of L5 on the lateral radiographs. The disc height, they have calculated anterior disc height, posterior, and the mid disc height. And they have taken the average of all the disc heights. The loss of disc height was compared to the superior disc, which they have calculated. And the slip, they have seen more than 3% as the case of enhanced spinal instability on the dynamic X-rays. So coming to the demographic data, they have enrolled a total of 218 patients, and they have followed them up to 2 years, but few of them have lost to follow-up. So the final follow-up was 173 patients, out of which 96 were men and 122 were women. The average age of around 69.7 years. So according to their classification of early, advanced, and end-stage diseases, they have maximum number, that is 145 patients in the advanced group, 15 patients in the early group, and 13 patients in the end-stage group. The recovery rate was the maximum in the early stage, whereas the advanced group has 62% of recovery rate. So according to them, they have required additional fusion surgery in only 5%. That means out of 173 patients they have followed up, only 9 patients required additional fusion surgery, and all of these were in the advanced stage. So the graded recovery rate, if we calculate, so it was excellent in most of the cases. Greater than 70% of the patients had excellent or good clinical outcome. And according to them, less than 10% required reoperation rate, out of which 5% were revision decompression surgeries and 5% were fusion surgeries after a follow-up of 2 years. So broadly, they categorize this degenerative spondylosis into 3 common categories because the clinical encounter, what the surgeons encounter in the clinical practice, most of them have this stable listhesis with healthy disc or a dynamic listhesis or a stable listhesis. So they believe that this type of subgroup analysis would allow them to functional classification system in regarding to pathological as well as the clinical results. So the study demonstrates that nearly all the patients who had unsuccessful minimal invasive surgery were in the advanced stage. Spinal fusion may be necessary in patients with symptoms due to spinal instability with the predominance of mechanical axial symptoms, patients with dynamic instability. So they came to the conclusion that in the patient's perspective, undergoing a microendoscopic decompression is a relatively low risk intervention compared to the fusion. And the population health perspective, it would certainly be more advantageous to treat these patients initially with minimal invasive decompression. And if necessary, only 5 to 10% of the patients may require fusion in the future. Whereas if you see patients with failed fusion procedure, it may be little difficult to address them because they may have come with pseudoarthrosis or adjacent segment disease, which requires additional fusion or more complex revision procedures. Moreover, the limitations of the study were they did not take into consideration the subtle anatomical factors such as the presence of facet effusion, facet morphology like the sagittal facets, facet tropism, and the facetal arthritics factors. So these are all the limitations of the study. And as being a retrospective cohort study, it has its own limitations. To summarize, microendoscopic decompression is an effective treatment modality for patients of degenerative spondylolisthesis. Only 5% of the patients requiring additional fusion surgeries and 5% requiring revision decompression even after the follow-up of 2 years. So they stated that only a small subset of patients may actually require the fusion surgery, given to the limitations in clearly defining the patients in societal as well as individual cost of unnecessary fusion surgeries. And this microendoscopic decompression represents a optimal first-line surgical treatment in most of the patients with degenerative spondylolisthesis with symptoms of lumbar canal stenosis. Thank you.
Thank you, Devanand. This journal article is open for discussion. Devanand, from the panelist, I would ask Dr. Karthik, can you evaluate what are the what do you get from this article? Because there are certain issues from this article, but if you have gone through the article I already sent to you, can you just evaluate and make the comments?
Yeah, the article highlights on the pathological classification, pathoanatomical classification, which is so far not been very clearly described. So that's one good thing about the article. And it also goes on to differentiate and saying which one would probably benefit with the fusion or which one would likely to go in for a problem as compared to the random idea of fusing every degenerative listhesis, which we have a lot of articles are propagated in. The downside on this is there is no clinical correlation in terms of back pain or stenotic pain or radicular pain between the early advanced and the end stages. Which of these patients had this? When they did the bilateral lateral radius decompressions, what was the outcome on those were not very clearly highlighted on this article. That is what I would, that particular thing would have made a lot more difference into assessing which patient would have been on what categorization would have been.
So there are 3 points that I want to make from this article. One is that they have defined 3 stages. The first stage was an early stage, but the number of the sample size from the early stage is only 15 out of 173. So I think that's too less. And even if you go to the end stage, that is only 13 patients. So most of these patients were in the advanced stage. So the other rest of the two samples are not that much statistically significant. That's what I feel, because only 15 patients from 173, you cannot conclude much in that, or 13 patients in the end stage, you cannot conclude much in that. The second part is that they have said that there is a 10% of revision rate in advanced stage. Mostly these revisions were in the advanced stage. Am I right, Devanu?
Yes, sir.
Yeah,
All the
so
patients were in the revision stage.
they were all in the advanced stage, and this is the stage where we get maximum number of patients. That's why they had selected, because it was a retrospective study. And
Yes.
10% in 2 years' time is quite a high number. That's what I feel, because if you want that these patients should be followed for more than 5 years to know whether there is a persistent post-operative instability which develops or not. So that is another thing, because 2 years follow-up is, of course, it's good for publication. But I think if you want to take it to clinical practice, this is one of the article that I would say that 2 years is too small a sample size. Anybody want to comment on this, like PC or Dr. Rajakumar? Vishal is there.
Yes,
Vishal, you want to comment?
Yes, I think this study is very good, and it leads towards the MIS. The outcome is 10% resurgery. I think is also good for the patient's sake, because the fixation itself is also it's a rather adjacent segment pathology, and the cost to the patient, and the most of the patient of Indian scenario, they want conservative and less surgery, and implantation cost, everything, and the morbidity, timing, etc. So the study also indicates that only the 10% patient needs even the advanced stage of the listhesis needs resurgery. That is the point I want to highlight.
Okay, Vishal, do you want to comment on this?
Well, 10% revision rate is something
In 2 years' time.
In 2 years' time is not something that is acceptable. One second thing is, if it's only in the osteophytic stage, is actually the stable phase of lumbar canal stenosis, where there are osteophytes and the disc is degenerated, the height is gone. And if the patients are presenting in the stage 3 of this classification, it is already a disease which is not healed by nature. Like majority of canal stenosis are going to be stable by the fact that it has become osteophytic, and the facets have become arthritic, and the disc mobility is gone. So if anybody presents in the third stage, for me, I mean, it's absolutely anecdotal, but for me, it is a case of decompression and fusion. A 10% revision rate would be disastrous in a country like India, where, I mean, I look at it this way: patient pays for it. If it is 10% at 2 years, at 5 years, it's probably going to be more. And it is going to give a bad name to a good surgery by not fusing such patients. So this paper, I don't agree with the finding that you should decompress a stage 3 or a stage 2 patient, because obviously these are patients who have failed conservative management or would do well just with a decompression. These are people who should be fused.
There is already controversy. One more comment I would like to make is that Matsunaga is a person who did a natural history study of this degenerative listhesis. And in his paper that he had a long-term study for, I think, I just remember it's often is of 10 years follow-up. And nearly 30% of these patients had a post-operative instability. I think, so that means that we require a longer follow-up. And it's too early to conclude that only 2 years follow-up and in an advanced stage. And if you see this anatomic classification, it's very good that in stage 1 and stage 3, you can go for a decompression where the results are good. But we need further information on how to deal with the advanced stage. That's what my conclusion would be. And I would ask Dr. Rajakumar the last comment, and then we move on to the next paper. Unmute, please.
Am I okay? Can you hear me?
Yes, yes, yes.
Good morning, all. It's a nice paper to discuss. Obviously, there are issues with the paper which has been highlighted by all the speakers. One thing that stands out is in any comparative study, when you are making a so-called group, if the weightage of the group is not equal, then you end up getting a very skewed kind of outcome. So in this paper, the disparity in the groups is very gross. One cannot compare this completely disparate groups and then come to a conclusion. It highlights a few points that if there is a very early stage, you may get away with a decompression, but as the stages tend to go on the higher side, you end up getting more fusion. It just shows a tendency towards it, but I don't think this conclusion can be made in a very strong way. That's all I'm trying to understand from this study.
Correct, correct. Last question to Devanand. Will you change your practice after this article? Because you are coming in a center with a lot of fusions.
Yes, sir. We usually end up fusing many of the cases. But if there is no classical dynamic instability demonstrated on flexion extension in radiographs, we still go for decompression. But according to this study, I may not change my practice as of now.
Okay, thank you. Thank you, Devanand. Yeah.
Just one point.
Yes.
So, see, it is only in the advanced stage, that, all these things settle down, that it reaches a stable zone. So at that point of time, you skillfully decompress, you'll be doing you will probably not render it unstable. That is one point. Second is, this is too low incidence, 5 to 10%. So in contrary to the possibilities of, if you fuse this patient, the collateral damage, the incidence of pedicle screw malposition, the incidence of cage back out, the incidence of pseudarthrosis, the incidence of ASD happening. Now with sagittal balance issues, the number of segments you need to fuse just for a one level listhesis, they're all, the proportion is much bigger when you open the box of fusion, So I think you need to have a balance. You need to have factors which will define. Of course, long-term follow-up is important. I don't want to waste much time.
Yeah. I know that there are so many issues that we need to further classify this, that whom to decompress and whom to fuse. But I think we will move ahead for the want of time. And your point is very well taken that, of course, MIS is a very small surgery compared to the fusion surgery. But I would now invite Dr. Ravish Patel to present another journal article. And over to Dr. Ravish. Please introduce yourself, Ravish, also, just before starting, so that everyone knows you well. Please share your screen.
Okay. Good morning, everybody. I am Dr. Ravish Patel. I am a consultant spine surgeon at Sunshine Global Hospitals, and I have done my spine fellowships from Bombay Hospital and National University Hospital of Singapore. So today I'll be presenting this paper, which was published in Journal of Minimal Invasive Spine Surgery and Technique. So it is about percutaneous cortical screw fixation as a method for posterior spinal stabilization. This was a study from Swedish Neuroscience Institute from US. So as we know classically that pedicle screws are considered the gold standard for posterior spinal fixation. And so far they have stood the test of time. The only problems that we face while putting pedicle screw is we require a wide dissection. And sometimes in osteoporotic patients, the biomechanical strength is not adequate. So alternatives have been proposed by Steele and Santoni in 2009, which is known as cortical screw. It is in a completely different direction, medial to lateral and a caudal to rostral trajectory. So far, after a decade of research, what we have at present is that cortical screws today, they require less soft tissue dissection, and they have a better pull-out strength than pedicle screws by about 30% because they have a cortical bone purchase. So what we don't know so far is there a MIS way to do cortical screw insertion. So this study basically tries to answer that. It is a cadaveric study for feasibility of percutaneous cortical screw. They have selected 4 fresh frozen cadavers with an average age of 80 years. All the screws were inserted with a fluoroscopic technique with a 1.5 centimeter skin incision for each screws, and to avoid any bias, all screws were instrumented by a single experienced MIS surgeon. So they instrumented all the cadavers from L1 to L5 level. All right-sided screws were cortical screws, and all left-sided screws were pedicle screws. So for cortical screws, the starting point was the inferomedial aspect of the pedicle. As you can see the left pedicle marking, it is about 5 o'clock position for left pedicle and a 7 o'clock position for the right pedicle. So the trajectory is directed superolaterally. So the direction is medial to lateral and caudal to rostral. In fluoroscopic lateral view, the trajectory is aimed towards superior end plate, and usually in standard cortical screw, it is aimed towards posterior 1/3 of the superior end plate, but in this case, they have aimed towards slightly anteriorly, that is anterior 1/3 of the superior end plate. So pedicle screws were also inserted with a standard lateral to medial direction and parallel to the superior end plate. And after putting all these screws, they tunneled the rod through X-tabs and screw caps were applied. After doing instrumentation, all the cadavers were dissected by a separate surgeon to inspect cortical perforation, medial, lateral, superior, inferior. They did full laminectomies and they did lateral dissection. They believe that direct visualization is better compared to CT evaluation of the placement of screws. So what they have found is there was only single breach noted in a cortical screw, and that was in the posterior 1/3 of the vertebral body, and it was not endangering any neurovascular structure. Apart from this, all screws were placed perfectly according to the study. So with this technique, so basically pedicle screws, open pedicle screws, they are a lot more invasive. So cortical screws, they in a way are less invasive compared to pedicle screws. And with this MIS technique, they have further tried to reduce the invasiveness of posterior spinal fixation. So what we have so far is the cortical screws, they have less blood loss, they are less morbid, and there are shorter length of stay observed in literature, and hence they are better suited for an obese patient. They have better insertional torque, pull-out strength. It has been observed by many biomechanical studies. And even there is a biomechanical study to evaluate the strength of a failed lumbar pedicle screws when cortical screws were used as an alternative or a salvage surgery. And they have observed that even cortical screws, they have good strength even when they are used in a salvage setting. And so far what has published in the literature, there are equivalent fusion rates observed with that of a pedicle screw. So with this technique, there is a further advancement. According to this limited study, what we can say that the cortical screws are feasible in all the lumbar levels, L1 to L5. Fluoroscopy guided technique, there is less risk of lateral breach. And the good thing is that it can be inserted in a lateral position. So this screw may be ideal in future for a lateral interbody fusion where you rely on an indirect decompression. You don't want to decompress posteriorly, then in the same position you can instrument the cortical screws at the fused level. Also, there is, as observed in this study, there is inherent less risk of facet violation because of the inferomedial starting point, and no facet violations were observed in this study. Of course, there are many limitations with this technique. The first limitation is you require a perfect AP and lateral fluoroscopic view. You should be able to visualize the pedicle carefully. These screws, cortical screws, have a medial screw head prominence, and so they can be inserted after decompression or in cases where decompression is not required. And if you decompress aggressively, there is a potential chance that the cortical screw construct may be weak, or it may predispose to failure or a past fracture. And there were studies before this also where they have shown that acute angulation of cortical screw is is limited by the midline structures like spinous processes. And in this technique, they have not encountered because they have mentioned that they have used less acute angulation. And so they say that the technique is a hybrid of a bullseye technique and a cortical screw technique. If you look at the literature, there is only one similar study published about percutaneous cortical bone trajectory. This is using a mini open T-lift technique, where they have used almost similar trajectory but slightly more acute angulation. And in that study, they have obtained comparable results in 20 patients with comparing pedicle screws and cortical bone fixation. Two problems that they have encountered is medial angulation. With the help of the normal MIS dilators, they were not able to angulate because of the spinous midline structures, and hence they have to use cut syringes for medial angulation while inserting tap and pedicle screws. So yes, this study has a lot of limitations. Definitely, it is just a preliminary study, but it provides basic and anatomical foundation to support the technique. They have quoted that if they have to obtain a balanced comparison between pedicle screw and cortical screw, they require 760 instrumented levels, considering there is a 6% pedicle breach reported in the literature, and assuming that cortical screws are more difficult and there is about 12% breach, so that will require about 760 instrumented levels. The third thing which I found awkward is they have used 6.5 45 screws for all the cases. They didn't obtain any pre-insertion measurements, and they have randomly selected this size because it is most commonly used. So far, they have not observed any anterior breach, but I think for taking this forward to clinical situation, we need to have a method to measure this cortical screw track before inserting cortical screw length before inserting the screws. So my conclusion would be, although MIS cortical screw is feasible and technically comparable to pedicle screw in this study, rigorous patient selection and further investigations are necessary. Thank you.
Okay. Thank you, Ravish. Let's have this paper open for discussion from the panelists. Again, I would start with Dr. Karthik Kailash. Unmute, please, Dr. Karthik.
And this again, it's a technique for salvage rather than for a primary procedure, primary usage. This is what I would go with the paper as well as with the thing. In terms of the thing, it's a cadaveric dissection, so you cannot actually talk about whether the usage of this can be reciprocated onto a live patient where we are doing things. The only advantage which I can perceive from reading the paper was that it could be used as an alternative mechanism in terms of doing a lateral lumbar interbody fusion and proceeding to doing with this procedure in the lateral position itself without changing directions. In terms of technique and material, that's the only thing I could pick out as an advantage in this. But in terms of changing my current practice, I don't know whether this will help me in doing it any further.
Perfect. And Dr. Vishal, what do you think about the cortical screws?
I agree with Dr. Karthik. I only use them as salvage screws. A couple of issues that are going to come in minimal access surgery using this is going to be inserting them properly, especially at an 80-year-old patient with a really fat spinous process there. Getting a minimal access trajectory is going to be difficult. Even in lateral position, it would be easier to put the right-sided one. The left-sided is going to be a very tricky one to get your C-arm to show you that pedicle well and to be able to put a cortical trajectory. Having said that, it has very interesting alternatives in elderly, especially when you're doing a lot of Anderson lesions or a long MIS fixation in an osteoporotic fracture. This could be, like Dr. Karthik said, a salvage procedure. I don't see it replacing my mainstream pedicle screw that we are using right now in the near future.
Right. So coming this as an alternative, or because this paper was not used as a salvage procedure, they wanted it to be used as a primary procedure. And there are so many articles which they have used the cortical screws as their primary fixation points and fixation devices. And I definitely agree that for the salvage procedures, or if you want to extend the procedure like in adjacent segment disease, where you don't want to remove the pedicle screws, some papers have say that you can use this cortical trajectory in addition
they are
to
4.5 millimeters.
Yes, they are 4.5. I absolutely agree with that. That they are 4.5. That was one of the limitations and the apprehensions raised by Ravish. It was not because of the length that we are worried. It is because of the diameter of the screw, which is usually 4.5 rather than 6.5. And that's where we need to see whether our patients can take the 6.5 screws or not. So that is one of the comment that I want to make. And yes, Dr. Rajakumar, you wanted to say something on this.
Yeah, so in minimal access surgery practice, and when you are talking to everybody, you are saying that the midline incision damages the multifidus. Now, in any cortical screw procedure, you're going to strip that muscle away, if I understand right. So is there any way you can, anywhere is mentioned when you're doing the study, Ravish, what happens to the multifidus? Because so much has been spoken about muscle preservation. And if the idea is to put a screw somewhere, your idea is also to protect the muscle. So is there anything that has been done, or is my understanding not so correct?
Yeah, so there is this issue has been addressed not in this paper, but the similar paper about mini open TLIF. They have mentioned that when we insert percutaneous pedicle screw, we go through rotators and multifidus. So that, and whereas in cortical screw, we just we damage the multifidus. So that's what they have commented, that in a way a cortical screw will be less invasive to the posterior muscle. Second thing is that in this study, they have taken not a midline incision, they have taken parasmile incision. So they have not erased the muscle from the midline. So yes, definitely it will have advantage, but I think we'll have to wait for the clinical results before taking this into practice.
I think this is the first article where they have tried to put is percutaneous cortical screws. The rest of the articles they have is mini open. So that's why we chose this article, that this is the first technique and we want to adopt a newer technique, then we need cardiac cadaver studies.
I just wanted to ask one question as a continuation of this. My experience in using cortical screws is very limited. We have hardly an occasion to do that, and we have gotten away in our practice. Among this elite group of surgeons, senior and junior, how many have found this cortical screw advantageous in their practice? Just as an understanding, because if there is a definite usefulness, then in tricky situations, we can consider this as an exceptionally good alternative. So I just wanted to know the flavor of this among the surgeons who are in this meeting.
So I'll just come in here. It is purely a salvage screw for me. There have been occasions, especially when you're putting in 5 screws or 4 screws on one side, and in a grossly osteoporotic patient, this would salvage. But only problem is, well, like you said, the entry point, we are used to an entry point that is 2 to 3 centimeters lateral to the lateral aspect of the pedicle. That's seen on the C-arm for putting a percute screw. Here, we should be going more towards the midline. So in thin patients especially, we had this unfortunate situation where actually we had to go through the midline to go get inside there. So putting 2 of the same is not possible, at least in my hands. So one side you can put a cortical screw, and the other side you pray that those pedicle screws don't come out, because if it is impossible practically in my hands to put a percutaneous screw in a thin patient. I've used it maybe 2 occasions for elderly in Anderson's lesion. To get the rod across, to get them aligned, is because you have to change everything. You cannot just change that one screw. You have to change all your screws to that trajectory, which is not okay. Navigation helps, yes, but otherwise it's a difficult thing to incorporate in clinical practice.
Amit, bhai?
Yes, so I have never used it in my clinical practice. If I have to change, I'll change the whole thing, but never use the cortical screw. So I don't have any experience to share with you for this technique. Yeah, Ajay.
Ajay?
I have done it on experimental basis only. They are good screws, but needs more radiological shoots. That is one. Secondly, the screws what we are going to use or we have used is pedicle screws. The profile of the pedicle screw itself is big. And actually these pedicle screws, what we are using sits in between the muscle planes when you are putting the pedicle screws. And here it is actually out and prominent. Thirdly, the entry point is a bit slanty point, and you get hold of a slanty point where you have to enter, because in pedicle screw you are finding the cancellous bone to get entry into the pedicle isthmus and catch the cancellous bone. But here you are taking an entry through a cortical bone. So to get the first entry itself, you may slip frequent. So you have to first acquaint yourself to an open thing, and then you may definitely mature to this. But at the same time, why these innovations are coming out is to make it more minimal access. Secondly, to combine with single lateral access, as Dr. Karthik told. Thirdly, with regard to the neural supply, all neural supply to the back muscles come from the lateral to medial. For that sake, the midline open surgery preserves the neurology of all the muscles. All pedicle screws what we put, all are being put from the transverso-facet groove, which houses the medial branch and the motor supply, which is going to the multifidus, and which you invariably damage when you are putting a pedicle screw. There are n number of studies of the denervation of these muscles in the literature. But that is the most out and the most acceptable method. So we still continue with that. And once we are fusing it, we have to just forget about this. And that could be one of the reasons why you may be losing that proprioceptive part of your back's feedback, and you have some stiffness in this group of patients because you are de-innervating this group of muscles.
Nice. Anybody wants to? Yeah.
Arvind has used it. Arvind, are you there?
Yeah. So initially these cortical screws came as a breath of fresh air. I thought it would revolutionize the world, but there are hardly any articles. There's not much attention to this particular, apparatus. So I'm not sure whether they're getting popular or they'll go down the drain.
Fine. So I think what would be your conclusion, Ravish? You have read the paper and you are a young budding surgeon and you are going to take this ahead. Whether you will accept this or you want to change.
Yeah, so the paper is interesting when we look at the way the screws were inserted. Definitely, previously I have seen cortical screws insertion in cadaver. I have done it, and I find it's technically difficult. As Ajay sir mentioned, that there is a thick bone in the pars superior facet junction, and it's very difficult. You cannot change the trajectory once you have made the trajectory. So, according to me, cortical screws are not a good option at present. But looking at this paper, I think it is definitely has an edge over the open cortical screw. And I would, at present, I would only use it for a salvage situation. Apart from that, I am not keen on taking this at present.
They have tried to define a very good technique. That's what I feel, rather than open this MIS way, where they have given this 5 to 11 point and the 7 to 1 point on pedicle and fluoroscope. So that's the only takeaway that I can have from this paper. So if there are no further comments, we go for the case presentations. And I would invite, I think it is Varun, because they were the left outs from the last sessions. So I would invite Dr. Varun Agrawal to present this case. Yes, Arun, please share your screen.
Thank you, sir, and a very good morning to all. I am Dr. Varun Agarwal. I am practicing minimally invasive spine surgeon at Bareilly in UP. So endoscopy and navigation are basically seen as two extreme ends of the spectrum of minimally invasive spine surgery. And maybe we can bring these two poles together as the techniques develop more. And this is one case which may highlight this point. So I'm presenting this case here. So this is a case of an 8-year-old male. He had complete quadriplegia at presentation. He was a neglected case, and almost 8 months had elapsed by the time he presented to me. And on the radiology, there was a occipital C1 assimilation and a C2, C3 assimilation. There was a subluxation going on there, and there was a basilar invagination, and you can see clearly that how the cord changes have started appearing. The patient had almost grade 2 power. So this is there. And you can see the basilar invagination and the fusion of the C1 to the occiput. And this is the CT angio of the patient, and you can see that the vertebral artery course is also overlying the joints, and there is a anomaly there. So what are the traditional options? This is traditionally open surgery when we consider for these patients. Transoral odontoidectomy is one. Goel-Harms fixation is one. DCR technique described by Dr. Sharat Chandra, that is there. But all these would require a posterior dissection, and the vertebral artery, as we saw, is on the way in both the joints. So it's a little complicated case for that, and a little dangerous to the patient also. So we also have some endoscopic and minimally invasive options which we can consider. And so this is a case report of an endoscopic endonasal odontoectomy in a child. So these are some various endoscopic options. Endoscopic endonasal transclavial transodontoid approach for the ventral decompression has also been described in this article by neurosurgical, published in the Neurosurgical Focus. Another is the endoscopic transoral excision of odontoid, and for the irreducible atlantoaxial dislocation. So all these, and there is this risk of transoral surgery. Everyone is well aware of that. So tube surgeries have also been described for such conditions. And the microendoscopic anterior approach for irreducible atlantoaxial dislocation. This is a surgical technique described by Yao Sen Wu. And in this, they used this tube retractor, which they modified for the anterior axis, and did the decompression and odontoidectomy. So this is how we approach this case. Can we still go a little more MIS on this? So this is how the patient was positioned on a Mayfield retractor on a radiolucent frame. And this is the endoscope, which we use to do the odontoid excision. And you can see that a navigation tracker has been put up on the endoscope itself. So this is how it looks like. It gives us the direction, gives us the orientation radiologically as well. And you can see. So with this, you can see that the transoral surgery is avoided. And the same normal anterior approach to the cervical spine in a minimally invasive way with the burrs, etc. And this is the result. So you can achieve a good odontoid excision. So these are the these are the pre-op and post-op, and you can see that the odontoid excision has been achieved. And this is how it was fixed posteriorly. And this is the result after 20 days that the patient has improved. And the cord edema will take its own sweet time to settle. So that the patient is well on the way to recovery. So this has also been described in an article, full endoscopic uniportal odontoidectomy and decompression of the anterior cervicomedullary junction using the traditional retropharyngeal approach by Dr. Sebastian Roten from Germany. So these are his articles. So this is how it looks like, where the endoscope is passed and the odontoid excision can be done. The addition of navigation also helps for the orientation during the surgery. So the key points is that acute or progressive myelopathy may necessitate direct anterior decompression, and various techniques with individual advantages and disadvantages are available for the direct anterior decompression. Compared with the transoral and transnasal approach, the retropharyngeal approach can offer a sterile and direct route to the craniocervical junction. The full endoscopic uniportal surgical technique with anterior retropharyngeal approach was found to be sufficient and minimally invasive method with the known advantages of an endoscopic procedure under continuous irrigation in these operated patients. And it's a different surgical technique and should not be considered only as competition, but as an alternative and a complementary technique. So thanks for a patient hearing, and I invite any questions.
Thank you, Varun. And this case is open for discussion. A very nice technique. So there are 2 or 3 things. One is the discussion on the case itself, whether the procedure was required or not. And the other is a discussion on the technique, whether it is going to be feasible in future and it has an advantage. And I think from all of us, I would invite Dr. Rajakumar to comment on this, coming to occipital-cervical junction.
Varun, first of all, I must say it's a very good technique you have presented. Congratulations on that. I have been watching your techniques over time, and I'm very supportive and appreciative of what you're doing. However, I want to make certain points here very clearly. I want you to share your screen and show me that slide where you are standing and doing, and at that time, I want you to show me the extension position of the patient.
So let me share my screen again, sir.
Yeah. Just hold on there. So I want you to concentrate on the images that you have got. You have a nice extension, and you can see the odontoid has reduced completely there in the above picture, what your arrow is showing. Can you see that? Yes. So I want to make some points here. It's just a fine point. It is not to detract from the good case you have done. So there is, and there was an understanding years ago that which of those atlantoaxial dislocations are reducible or irreducible. The initial discussion we used to have at one point in time was that certain of the atlantoaxial dislocations, if they are given traction for a period of 1 to 2 weeks, they reduce and you can do a simpler fixation. That's number 1 point. Number 2, after Goel's understanding of distraction of the joints, the so-called irreducibles have become reducible. That's the second point. The third point is, many times what appears irreducible on preoperative images, if you were to put a traction under anesthesia and you were to do a spin or a X-ray lateral, you will find many of them are reducible. So even if you have planned a transoral odontoid decompression, whichever way, microscopic, endoscopic, transnasal, transoral, any other technique, the moment you find that it is reducible on the table, you can and you could do a posterior fixation of the nature that you have done. So my only thinking was, could you have avoided the oral or a odontoidectomy at all in this particular patient, given the fact that under anesthesia and extension, the degree of reduction has been substantial. And when you're doing a posterior procedure, even if the reduction is little less than 100%, let's say 90%, 80%, if you do an adequate posterior decompression, you can get a similar outcome. This is not to detract your technical abilities or your fantastic OT that you have, which is mouth-watering to all the other surgeons to see. Congratulations on having that fantastic capability. But this is the only way I would look at it. This is just a pointer which I look differently.
I think
Yeah.
Yes,
So,
Varun.
I took your points under consideration, sir, at the time of planning this case. So my concern was, if you see the pre-op images, one was that you can see here that the tip of the odontoid is quite extending into the cranial junction. And the other point was that the vertebral artery is overlying both the joints posteriorly. So I was not very keen on dissecting that out and maybe putting the vertebral artery at risk in trying to put a spacer or maybe distracting the joint. Mind you here that occiput and C1 are fused together, and so is C2 and C3. So there is a big mass which is there. And even here you can see that when we draw the Wickenham's line and all that, there is a bit of basilar invagination there. So under those circumstances, I thought it is better to do a odontoidectomy or any decompression there. So that was the concern. So it has reduced in, it appears reduced in the extension, but we cannot fix this patient in such an acute extension position of the neck, because then the eyes would only be seeing towards the sky. So that was one concern there.
Thank you, Varun. Was a great technique, I would say. As a technique, it's a very, very innovative, nice way to do an odontoidectomy. There is a lot of controversy, and I would not go into that controversy whether it is anterior or posterior. That will take a full lot of time, whether this could have been done from posterior or not. But the positive point is that you can do these things from the anterior retrofetal approach, which is much less invasive, and that's a good takeaway from your case. Thank you, Varun. And we will move forward with another case from Dr. Akshay, who was also left out from the last our MISSAB tutorial. Yes, Akshay, please share your screen.
Hello, everyone. I hope you can see my screen. I'm Dr. Akshay. I'm a consultant neurosurgeon and spine surgeon, presently in Astra CMA Hospital. I've done my fellowship in minimally invasive and advanced complex spine surgery from Australia. So today I'd like to be talking about an interesting case presentation. Yeah. So this is about a 71-year-old male who had presented to our OPD with low back pain, with pain radiating around along the legs, along the L5 dermatome left more than the right for about 5 months. The low back pain was not very intense. It was more of a radicular pain and claudication. His claudication distance was about 100 meters. He also had numbness and tingling sensation in his buttocks and the posterolateral aspect of his thigh. He also had, on examination, there was weakness of dorsiflexion in the grade toe and ankle, and about grade 3, bilateral EHL or grade 3, and he also had sensory deficit about, there was left L4 and L5 hypoesthesia. Vascular examination was normal, and there was no other past medical history. So these were the X-rays that we had obtained. The whole spine standing X-ray showed that there was a mild degenerative scoliosis with an SVA of around 5 centimeters, PT 19, PI 69, LL was 63, as well as the coronal cob angle was around 17 degrees. The flexion extension X-rays also were done, which did show that there was a significant lumbar degenerative disc disease. With grade 1 listhesis at L5S1, but it was we felt was more or less stable on flexion and extension. And these are his MRI images, the T2 MRI sagittal images, which show that there were multi-level degenerated discs with canal stenosis at L1, L2, L3, L4, L4, L5, as well as L5S1. And here on the coronal view, you can see that there was a mild scoliosis as well. So the axial images over here show I've just taken these L1, L2, L3, L4, and L4, L5. These were the significant canal stenosis. L1, L2 actually showed that there was a disc prolapse, and L3, L4 was significant. The most significant canal stenosis was at L3, L4, and L4, L5 as well. L2, L3 and L5 S1 were not that significant, is what we felt. So this is the diagnosis. There is multi-level lumbar degenerative disc disease with L1, L2 prolapsed intervertebral disc, L3, L4, and L4, L5 severe canal stenosis, and L5 S1 grade 1 listhesis with degenerative scoliosis. So before I go ahead further, I want to just have a couple of options on the table here. What are the options that we had? So the options that we could consider were, first of all, whether it is what needs to be done, just a conservative management or maybe injections, multi-level decompression, whether it could be done tubular or endoscopic versus open, or whether this particular case required fusion. There was a deformity, whether the deformity needed any correction or any other options.
Yes, Akshay, I would stop here and go back to your first, the axial cuts of the MRI.
Yeah. Yes, sir.
Yeah, so I'll just put forward to Dr. PC Day. What's your option? Yes, Dr. PC.
Yes. It's a multi-level. I think the listhesis is also there, this L4, L5 S1, and also the more disc in the L1, L2, and the stenosis at the maximum at the L3, L4, and also L4, L5. For me, it is a simple surgery for this mobile descent technique, discectomy at L1, L2, and the decompression 3, 4, 4, 5.
So you are going to do 3 levels. One is L1 to discectomy, and the other 2 levels, that is 3, 4, and 4, 5, you will do over the top decompression.
Correct.
That's what I would say, right?
Yeah.
And yes, Vishal, what are your options?
Sorry, just one question to Akshay. Akshay, what's the element of his backache?
So that's what I mentioned right at the start. His backache was not that significant as compared to his claudication and radicular symptoms.
There are 2 ways to do this. One is a complete detent to ileum fixation with decompression with a TLIF at L5S1, L3, 4, L4, 5, and decompression at 1, 2 with restoration of the sagittal balance, which will be like a very long, tiring job. I have seen some surgeons do this minimal access. Unfortunately, it's beyond the scope of my surgical skills. So other option, like Dr. Dey says, is focused decompressions. My main worry here is going to be the L5S1 junction. Other thing is the patient is 71 years old. Is I mean, not very old, nor is he very young. So it's somewhere in between. So you got 1.5+ decades of life left in this guy. I would go for a full-blown detent to ileum fixation, or just leave it with some pain block till he can manage. But he's already got a neuro deficit. I would not want to come back at 75 and redo the whole thing, because by that time the this is going to progress.
Okay, so your option is to go to a full-blown fusion from T10 to
You got
S1.
to do it. You got to do it one. The patient needs to understand it's going to be a very morbid procedure. It's going to take a long time to recover. The complication rate is like 30%. That vis-a-vis, like you can do a decompression, add maybe a few years of some mobility to him, but this is not going to go away. This is an unstable situation. And the L5S1, even if in the axial cuts is not showing a central canal stenosis, the lateral recess is completely blocked, one. And this is done in the supine position, which is an unloaded spine MRI. So when this is going to be standing, this there is going to be a slip, and because this is a dynamic listhesis at that level, and cause more stenosis. So the L5 is probably getting hit more in the lateral recess of L5S1 than at the 4-5 level.
Okay, point well taken, Vishal. I'll come back to PC. Can you move forward, Akshay? One slide. No, one slide forward. I just want to counter, for the other one. The other axial cuts from, yeah. Yes, PC, I would put in you again that at L12 you see the facets are very sagittal. At L12 the facets are very much sagittal. And at L34 you have a more of a foraminal stenosis at L34. Right. So are you not worried about further destabilizing these two when you are doing a pure endoscopic decompression?
Yeah, absolutely. This is if you are very much acquainted with your instruments and you are going to the opposite side, undercutting the spinous process and little bit and go to the opposite side lamina and decompress up to the foramen is not so difficult. And without compromising the facet joint, etc., and rather preserving the facet joint, only the removing of the little bit of the facet hypertrophic part, the medial aspect of the facet, is enough and to decompress the bilateral foramen and the lateral recess.
Okay, I'll put in Ajay here for his last comment and we see what Akshay has done. Ajay Krishnan.
I would share out with the patient, and as Vishal also told, think about a blocking procedure or anything which can relieve his symptoms and get back to his stable zone. That's what you want to. Going for an extensive surgery is not the end in this patient. At the same time, for me, this patient has a deficit which has a quick onset, and I believe that the soft disc at L12 is something which has contributed to the acuteness of what he developed. At the same time, L34 may be there. L45, there is facetal slip. L5S1, there is lateral recess, foraminal there. But I would give my all doubts to this L12. And if I can, in MRI images, on packs, identify a soft disc there, I will even attempt an endoscopic transforaminal fragmentectomy here at L12. If I can prove that this is soft and it is very much related to the acuteness of his symptoms, I may get away with the transforaminal only. That doesn't end, the story doesn't end here.
Okay. So now we have got three options, a selective L12 decompression, the decompression from L12 to L45 and a full fusion. Yes, Akshay, what have you done?
Yeah, so that's what I'd like to come back to these options, to the similar options which we also had considered. And the points to consider here are, first of all, his age, 71-year-old male, and his symptom onset is not that chronic. It was more of an acute, maybe about 5 to 6 months onset of more of claudication symptoms than his back pain. So we really asked that question to him, what would he really want? What was bothering him more? Whether his back pain was bothering him more, or what did he want to get rid of his claudication pain? Rather than, so we had also considered these options. One is whether just conservative injection, but again, he was having a neurological deficit. He had a grade 3 EHL weakness, as well as probably initial stages of foot drop as well. So obviously, just a conservative management was not there on our cards.
Yes, Akshay, you just move forwards. We just want to know what have you done.
So what we ideally did was, we did L1, L2 discectomy on the right side, as well as a L3, L4 and L4FA tubular UBF, that is bilateral decompression. So with this itself, patient had a significant improvement post-operatively, and his pain also was reduced, and claudication pain also improved. So that's what we did. Although we did discuss the option of an entire deformity correction, but we did not think that that was what the patient also wanted, or that was not really required in this particular situation. Just want to share, maybe you can...
we just go, we stop with this thing, and we may go for a last comment from Dr. Kartik Kailash. So this is what was done after the discussion with the panelists. Kartik, your last word on this.
Yeah, I think I will go with Ajay on this, because it's a localized thing at L1, L2. If I can get away by doing a procedure like a transforaminal discectomy at L1, L2, I will get away, wait, watch, and if further problems happen, then think in terms of doing a decompression at 3, 4, 4, 5.
Okay, so okay, so for identifying, would you give, one last question, would you give an block at L12 to check whether the L5S1 symptoms are relieved or not?
Yes, that's a very good idea to do it. The block can certainly be done. and then if it's found positive, can definitely go ahead with these things.
Right.
Because we can do a smaller procedure and try and get away.
Okay. Nice. Very good case, Akshay. So we move to the last case and then to the lecture of Dr. Ajay. The last case by Dr. P.C. Day.
Is okay?
Yes.
So this is December 2009. The patient is 65 years male, is a general surgeon with no medical comorbidity presented with me. This is gradual progressive bilateral neurologic claudication for 3 years and diffuse tingling and numbness, occasional mild back pain. Walking distance is less than 200 meters, standing time is less than 5 minutes. Rest relieves the pain and there is no bladder bowel movement. Activity daily living was affected because he was a general surgeon. He was wanted to operate cases, but he was not able to stand beyond 5 minutes. So that was the main issue, and the walking distance was reduced grossly. On examination, there was a diffuse tenderness of the lumbar spine. Then spinal range of movement was okay. Sign of the nerve tension was negative, and no neurological deficit. Distal pulsation was normal. His flexion extension X-ray was did not showing any instability, and this is the MRI, and this is the axial cut, the 34455S1.
So can you go back to the flexion extension views? So keeping this in mind, I would ask Vishal, how would you move forward? It's a 3-level stenosis. I don't see much of instability anywhere. Yes, Vishal.
So 3-level instability, rather
3-level
stenosis with no instability. General surgeons saw a lot of forward bending, a low demand life with the fact that he came to seek treatment at 200 meters of claudication. So obviously this is not a guy to go and fuse and do anything. I would just decompress 3 levels, maybe tubular or with interlaminar endoscopy. These are one of the 2 options to do this.
Okay, so you are not going to do a fusion or any open laminectomy standard type?
No, I don't think, except for a congenital stenosis, there is any role for laminectomy in degenerative stenosis. It is to be condemned. It is a disc and facet problem, and you need to address that. If you see any lumbar canal stenosis MRI, that is that is not congenital, there will be adequate space where you take the bony cut. It is only when when the axial cut is taken through the disc space where you find the stenosis, and that needs to be addressed. You need to do probably a laminotomy of the lower third of the lamina, where the disc has settled down and there is a bulge. Apart from that, there is no role for laminectomy in any lumbar surgery. It's like doing a colectomy for every appendix removal. I see that it as that invasive. There is no role for that. It's just a decompression at 3 levels. I think he'll do well.
Vishal, I find that there is some amount of stenosis congenital here. This is short pedicles. It is there. I agree with you, but there is short pedicles here. There is some element of
there is a congenital stenosis maybe, but he's presented in his late 60s. So he's lived 6 decades with this. So probably has a short stature and his body dynamics are that. Like most of congenital stenotics will present in their 20s when the bulges start, and there will be disproportionate symptoms to the amount of disc that is seen. This is not that kind of stenosis.
I would just point here, there are two things. One is what you're talking about is congenital stenosis in DAFs, in actually stenotic patients. That is a different category. But there is good number of patients who present to us in the elderly group who have short pedicles and with lesser interpedicular distance. These are also in this group of developmental canal stenosis, not the acquired ones.
Yeah,
acquired,
but they don't require a laminectomy.
If can you go to the axial cuts of the MRI? Okay, so what is your take, Ajay, now? Because we need to see the interfacetal distance also.
Definitely the contributing thing to the stenosis majority is from the facetal part. There is a developmental part, but that is not significantly contributing. That's why he has been non-symptomatic for 6 years.
Okay, so Vishal, will you do only a decompression or a laminectomy or a discectomy also at L5S1? You can see a bulge there.
So no, that bulge is in the center. By doing a discectomy, you are going to increase your dissection A, B, add to the instability.
Yes.
All it requires is a decompression of the infolded flavum, undercutting of the facets on both the sides, and that should do the job.
Okay. So coming to the point of 3-level decompression, I would have a last point from our secretary, Dr. Arvind Kulkarni. What would you do? Please come in.
So like many other spine conditions, this is an evolving pattern in this patient. It is not a static image. Maybe 5 years later, 6 years later, 10 years later, he'll have a different picture altogether. So it is just evolving. At this point of time, patient has stenosis. The spine is stable. I'll just go with tubular decompression at all the 3 levels.
Okay. Yes, PC, move ahead. Let us see what you have done.
So may I ask you to this any role of injection here? Maybe one shot or 2 shot.
You can try epidurals in all these cases.
Okay. Then go ahead.
Yeah, please.
So this was as you know, if this I'm a destined man, so I did this decompression all the 3 level. There was a single port for 4-5-5-1. As you know, this is the anatomical orientation. 3-4-4-5 can be approached from the single port with just tilting 15 degree up and 15 degree down, and we can very well go over the top and decompress the opposite side foramen also. And this was the patient after 3 years when in Bhubaneswar there is World Endoscopic Spine Society Congress. He was the chief guest, and in 2016 this September he came to me with a mild back pain and also some radiculopathy on the root of the L5, and that was the left side, and that was only for 10 to 15 days history. And then we did the X-ray and the MRI. X-ray shows there is a decompression and the laminotomy of the 3-4-4-5-5-S1. And there was a small disc at L4, L5. And then we thought about the conservative treatment. And we did the same time, that was the MRI of the 2016, 2-3-3-4-4-5. And there was a 2-3 little bit stenosis developed, but 3-4-4-5-5-S1 was okay. And this is the CT scan we did to see the adequate decompression we have done or not. There was a bony issue. So I did the CT scan also to evaluate. Because at that time he started of this surgery, he relieved from the pain, and only there was a 10 to 15 days history of this mild back pain and radiculopathy at the L5 root. And so this was the CT. We did this very well unilateral approach, bilateral decompression up to the foramen, and we were very satisfied. And then he relieved with the pain within say 15 to 20 days. Then he forgotten. This 3 days back, I called him with my interest for the presentation, and I did the X-ray of flexion extension and the epi view. Here it's showing this is the well decompressed. This is a sign of the laminotomy from the 3-4-4-5-5-S1 bilateral, keeping the central structures intact. And this is the 3 days before MRI. This is 10.5 years after of his decompression 3 level. And this is the 3 days back MRI. 2, 3, 3, 4, 4, 5, 5 H1. And this is the, so he is 76 years now, 10.5 years down the line after the index surgery. Professionally still active and busy surgeon, mild intermittent back pain he was complaining. Claudication pain sometime on the long period of standing is a very minimal, and going for morning walk about 2 to 3 kilometers, as he is very happy. Now I think Amit to conclude.
Yes, PC, a very nice case of doing a 3-level decompression and avoiding major surgeries like laminectomies and discectomies and fusions in a elderly person, very active elderly person. I think in a very good follow-up of 10 years, that does not show that there is the continuum of the disease like instability which is developing even after doing a unilateral unilateral to bilateral decompression. Very nice case, Dr. PC. Any comments from anybody, and then we move forwards?
Excellent.
Excellent. Excellent case. Yes.
Thank you.
So we come to our last part of the MISSAB, and we all know that the younger surgeons with whom I'm interacting, they are always asking, sir, how do you incorporate any new technique in your practice? And it's very important that because these are new budding surgeons, they don't want to lose the patient by doing damage to the patient. So this is a very common question, not only from the juniors, but even for the seniors where they have a rigid mindset not to change and they are happy with their old results. How to incorporate these newer techniques which are coming, and endoscopy is one of them. And I would ask Ajay to talk on how to incorporate this endoscopy in the spinal practice from equipment to indications. Yes, Ajay, please share your screen.
Thank you, sir. Thank you. So coming to the point, everybody want to incorporate the technique of endoscopy, or at least want to be associated with endoscopy in some form or other. That itself is justified by this talk, which is we are going to go ahead with. And the simplest way for learning anything is going to be to acquire it first. So this is the conclusive slide which I would put the first thing, that if you want to learn something, first of all, you have to acquire, start doing it. You can't remember when you learned to tie a knot of your tie till you were compelled to and you had a tie in hand. So the first thing is that you have to have an endoscope in hand, and it is the same way as you procure a car and start driving. This is not difficult. It is not at all difficult, but you have to have a hand on it and you have to start doing it rather than talking about it. This concludes most of the things, but at the same time, you can make it more complicated by answering a lot of things, questions which has been put forward by Amit sir also, the confusions which come to a mind of a senior or of a junior, whether you'll give an outcome, what if I fail, what is the cost, what is the cost of procuring, if I don't give results, if I fail, this is not the final answer. So there are so many confusions which goes through the mind, and in that case, to give a complicated answer to learn something is going to be, this is the complicated way of answering this. Take up a technique, read plenty about it, develop familiarity with it, play in workshops, start it, practice regularly for months to years, get covered by seniors, mentors, proctors, improvise your knowledge, extrapolate beyond what is there in the books and what your seniors have taught, and follow your passion, and finally your persistent attitude will make you successful. So this is the complicated way of having to reach to an epitome of anything which you start. And mainly it is going back to the basics. You have to be very good at seeing, reading, diagnosing. So the basic diagnosis always remains the same thing. You have to be pinpointing. Minimally access surgery will give rewarding outcomes with a continuous evolution of the patient's presentation. The pattern keeps on changing, but that point of time when the patient has presented to you, you should be able to pinpoint your diagnosis. That has to be with good clinical history and judgments and very good image reading. So that is very much important. And I would add to it that needle block is something which you have to master to be able to pinpoint that this may be. I'm not saying that it's not foolproof. It is foolproof. You will miss, you will have overlaps, but this nearly completes that 80 to 90% of the patients wherein you want to do a specific job. So, and the other thing what you have to do is you have to be very, very targeted. As Dr. PCD showed, you have to be very targeted. As Akshay showed, you have to be very targeted what you are doing. So you have to target, and the more difficult it is going to be with a more docking system. See, if you have floating system, any floating system like the microscope itself is a floating system where it can move. An incision can be small, but you can wander. So that is possible. With a bigger scope which you are using posteriorly, you can just manipulate and have a feel, and you can do a big job, even more than a laminectomy by an endoscope even. But what we are talking about is if you are using a docking system which get fixed to a particular point, you don't have much of a mobility. In that case, you have to be very precise and be at the target. And especially for interlaminar small scope surgeries or transforaminal surgery, this needs to be very precise and target. So identifying your target becomes very important. Dissecting around, that will help immensely. If you want to pick up transforaminal surgery, then transforaminal epidural blocks are what is to be started by you. You have to be complacent to give those blocks very frequent. You start with root blocks, then you give transforaminal epidural blocks. You go something which is just paramedian by say 5-6 centimeter, then you upgrade with longer needles and go more lateral and start giving transforaminal blocks. That makes you half job done. See, your needle has already reached the target where you wanted to. Now your next job is to put a endoscope over it or railroad it. Then the second part starts. So you have two parts in any endoscopic surgery, especially transforaminal, to place the needle at the exact point. And second thing is putting the endoscope there and doing the final jobs. So there's a lot of confusions on the equipments, the system, the technique, the philosophies, and there's a lot of to choose from. So if you see on this, interlaminar stenoscopy and UB is more easy to master because it gives you play. There is wider application of it. And at the same time, you can do a lot of things with it. But at the same time, with interlaminar small scope endoscopy or transforaminal, the application is limited. And that is the reason why it has not picked up too much in the society, and not everybody is able to do it. And it takes long years for you to actually come out with, say, handling complicated cases as well. But for all disc types, you can handle this. At least I am able to do. It may not be reproducible, but at the same time, it will be reproducible if you start doing it, definitely. See, this is some illustrative examples, like this is an extraforaminal disc which is there, and you do that specific point decompression with an endoscope under local anesthesia, and the patient is out. The patient walks out. So this is possible. This is exactly where your scope has entered into the disc. And this is our central disc, which was said to be a contraindication to a transforaminal surgery, are usually now handled easily by a transforaminal surgery. 5 years back, you won't find literatures wherein central disc would be handled by a transforaminal endoscope. Upper lumbar disc herniations. Midline surgeries always adds to retraction of the neural tissues at upper lumbar level. And for starters, it may create big problems. Experienced people may get away with it, with doing it in a very beautiful way. But at the same time, these are the group of patients wherein transforaminal works wonder, like this L2-3 disc. You just get away with a transforaminal surgery. Down migrated cases being removed, easy. A up migrated fragment can easily be removed. At all levels, it is possible. So the basic difference, what all I talked about right now, is inside out. So you have to start with block. You should go to inside out technique. What is inside out technique? Wherein you put your needle into the disc, the scope onto the needle, then you are doing the surgery. You are doing subannular decompression here. You cut the annulus there, and then you reach and angulate the scope to the epidural space and do your epidural work there. But at the same time, there is another technique on the transforaminal thing which you can do, is the outside in. That is a more macho and more mature technique. It is definitely good. It has got specific indications more to be done. But for beginners, those who have not seen too many with their mentors or teachers, it would not be a startup procedure. And I also myself did something after 4 or 5 years only. I did the outside in part after 4 years when I started 12 years back. So outside in, because it shows up, wherein what you do is you chop a part of the facet here by using reamers or a blind foraminoplasty. So herein you don't do a foraminoplasty in the inside out. You go into the Cambine's triangle. The natural boundaries of the Cambine's triangle is exploited. But here what is done in the outside in is that you widen the access to the foramen and the epidural space by widening the Cambine's triangle, and what you remove is the bony part, that is the facet. And the removal of this facet is a blind procedure with use of specific reamers, which will come to, and that definitely increases to a hiccup because you are directly reaming around the neural tissue and increases the chances of bleeding. So to start with, it is inside out. You may mature to outside in. So like central disc, for highly migrated disc, you may do this. Not at all into the disc, inside the disc. This is the needle which is placed. This is the facet which you have just rimming through. This is the scope which is placed. You are doing all things which is epidural. And if you see in the sagittal, this is all epidural. It's not inside the disc. It is docked at the disc, but not inside the disc. So for high migrated cases, you may have to do this and get away with removing the fragments. It is possible. You can do. For L5S1, specifically the other thing which comes into way is your long transverse process of L5. It may hinder the interfacetal distance. So, or the interpedicular distance, if it is high, it is very difficult to get your scope to the center. So in those cases, you have to do a foraminoplasty by an outside in technique in many cases. And you may have to do even a transiliac case, like this is the case. And this is where you have gone through the ilium to reach to here to remove the fragment. So it is possible. So, but it becomes more invasive. So outside in is more invasive. Transiliac is more invasive than the inside out. And it is a bit on the macho side of the surgery. For a recurrent disc, these are recurrent discs which is there. It gives excellent outcome because you are going completely to a virgin area and not going through old scarred area. And this can give you beautiful outcomes. Foraminal disc and stenosis. This is again very beautiful procedure. Like this is a patient with foraminal stenosis here, and you have cleared the root. You can see, and circumferentially you can see pattern space there. So this is where you are able to see. So L5S1, you can have a lot of stenosis there in foramen, and you can do adjacent segment disease. You are going to handle many, and if it is only a stenotic ventral component of part which is causing the problem, like in this case, the ventral part of the thing which is there, you can just cut away that part and have few months. This patient eventually I had to reoperate, but you can buy time in cases you can get good months to years for these patients. This is calcified disc, L3-4. Even for a posterior surgery, it is difficult to remove. So this you are able to remove. This needed further extrapolation of two scopes. Say one is from one side and the other is from the opposite side. You are able to remove it. And this is under local anesthesia. So this is all things which is there. But these are all possibilities. This should not be considered as indications. Like transforaminal for even stable listhesis, we have done few. It is got reported, published this year. Even Cortical syndrome. Last week I got an acceptance of 15 of cases of Cortical syndromes by transforaminal surgery. But this is possibilities. You should not consider this as indications. As you see a tachometer, this is the safe part of the riding. So where you need to use an endoscope as a beginner and you definitely get away with a good flying results, that is what you have to understand. And these are the classic indications which you have to think about. The classic indication is a paracentral disc prolapse at L4-5 or above L3-4 or L2-3, a foraminal disc, and finally discitis. These are the cases where wherever your needle has reached and the scope has reached, you will definitely end up decompressing or removing the fragment at least to 70 to 90%, that is for sure. So you have to start with this group of patients. And even if you limit yourself to this group of patients, you have done justice to the technique that it is feasible and it is possible. Extended indications and more extended indications we have just talked about, there is extensive things which can be done, and which is on your own experience, how many years you have put on. A few words about UB, interlaminar and stenoscopy. The indications are the same as that of the posterior surgery, but when you start a posterior endoscopic surgery, you have to start with specific posterior element stenosis of ligamentum fleum stenosis or low migrated disc fragment removal. So that is how you have to start. So you start with initial cases in this way, then only you go forward. And failure handling and complications are the most biggest and the big problem which you have to keep handling. This month I had a recurrence. This is L34 disc, which was a big disc. I removed the patient immediately. Patient was good. On 10th day he has a massive big recurrence, but only backache. He has settled. So you have to be very acceptable to what can lead to. See, this is a patient who got outcome, but I did a post-operative MRI to justify that I had done my job, and I could stamp that I've done my job good. But at the same time, failure. The patient is still with me and he is now okay, because now it is already 4 weeks. But you have to handle these complications. You have to anticipate. The same thing can happen with a posterior surgery also. But in a posterior surgery, you have created more space. This creates less space. This creates specific space. So you will be immediately into a trap if any more space compromise happens. So that's why you have to be more foolproof and prove that you have done the job, and confirm and prove by MRI. So I just suggest to all that you get a post-operative MRI to say that you have done your job. And coming to a little bit of inventories, you need a basic OT setup. You may have a class 1 OT as well, but IITV is the basic requirement which you have. This is under local anesthesia if you are doing a transforaminal surgery, and all other surgeries you are doing under GA. You need an endo tower. You may have a HD screen. You may have a simple TV also. You may have light sources of the best companies. You may have the the whole of the endo tower of a particular big company, spend huge lakhs of money, 30s, 50 lakhs. But most of the these endo towers are available in the corporate setup, and you need not invest into it. You may just go use that setup. Even with recorders, it is there. This is the camera which is there. A single chip camera can work for you. You may not go in for a HD camera, but a 2 chip, 3 chip, whatever camera you want to have, you can have, and they all work good. And now there is a whole lot of companies which are available, except the branded as well. And provided that you want to quit the Chinese products, you will find few of the Indian products as well. And this is the portable thing which I also have. This has got the screen with the light source as well as the camera. So this is something you can carry portable and use it. And this acts as a stepney also in case one of my system, the fixed systems of the tower is not working. These are available with stores. These are available in many of the other Korean and Chinese companies, and cost in between 3 to 5 lakh rupees. So that does all the job. So for you, so whole of the tower is just bought to a portable thing when you are traveling around to do surgeries. Irrigation, you can spend on these irrigators. I have these irrigators of Smith & Nephew, the Europumps. This gives good amount of fluid for any of the full endoscopic surgeries, but I'm not very comfortable with huge amount of fluid which is pushed on, and I in 95% of cases just choose that drip irrigation. This can be elevated to a 2 meters, 2.5 meters, and even can elevate to a roof level. This gives enough pressure, enough. But for outside in techniques, for more epidural techniques, you need more fluid. So temporarily I may use these techniques, but otherwise I'm using only the irrigator. Simple. Now this is a scope you have to choose. This is the main thing which you have to choose. This you should take a good company, and any scope which could be a diameter of 6.97 or 7.1 mm for a transforaminal scope, or the same scope can be used for the interlaminar also. If it is a wolf, like this is a wolf which would have an irrigator channel which is there, this is the working portal which is there, and this is the rod length system which carries the images and light. And this is the diameter which is material for us, and that diameter can be 4.1, 4.3, 3.7, 3.5 in various systems. The others, another system which I'm using is the Maxmore. So here there is another channel for irrigation, so that is additional. The wolf will have only one channel. At the same time, it is oblong, so it is flat, so it allows fluid to seep from the side of it, and that helps you out. Other thing what you need to understand is the degree of the scope. Say 20-degree scope, 25-degree scope, a 30-degree scope. A 20-degree, 25-degree scope would be good enough for you. A length of 180 centimeter is enough for you. Higher length is required for Western population. Higher length is required when you have patients with BMI more than say 35, 40. When it is reaching, then only you need to have a longer scope. But those group of patients are very less. So you need not go more than anything 180, 190 centimeters length of the scope. So 20-25-degree scope is good enough, and that is enough. A 70-degree scope can also be talked. So a scope like 70-degree, what it does is, this is a 0-degree scope. What is there? 0-degree shows you and makes you do what it shows, but a 70-degree will show you something which you will not be able to reach to. So a higher degree increases your visibility of into corners, but you cannot reach with the scope there. So it is just for inspectory purposes where you can have a 70-degree scope. 0-degree scopes are mainly for interlaminar, for UBEs you can use, and for inspection wherein you want to do a direct inspection you can do. Longer endoscope we talked. Graspers are the thing which you have to have. These are the disc punches which you have in the open surgeries as well, but these diameters vary. It may be from 2.5, 2.7, 3, 3.5. 4 also are there with the systems. This can be cup shaped, this can be longer one, this can be serrated completely. All these graspers work. The best hold is with the serrated graspers, and you need to have only 2 graspers, one 2.5, one 3.5. That would do the purpose for you. You have to understand that there is this thing also there, that is flexible graspers. Say this spring in the terminal part allows you to put it through the scope, and after it comes out or exits through the tip of the endoscope, it can go to an angle and catch the fragment for you. But more articulated fragment instruments or more malleable instruments, your vision, this may not happen in front of your vision. And in endoscopy, if you have done anything which is not in your vision, you may endanger things. So these are to be used cautiously and has got limited indications, but not for starting up cases. And this is what you have to understand with grab. The grab what you are going to have with of a fragment, that fragment needs to be pulled out through the endoscope. And if that fragment is not coming out through the endoscope, then you have to pull out the endoscope as a whole. So it doesn't make any difference as you increase the size of a grasper or the jaws of a grasper, or a double mouth opening graspers are also there. It doesn't help in achieving something better than a small mouth grasper. So you have to hold and just tease it and bring it out. And the more bigger the grasper is, that your vision is going to be impaired. So a 2.5, 2.7 grasper gives you good vision of the endoscopic view rather than what is a 3.5 or 4. So don't go for a jump for a bigger grasper. Annulus cutter, flavum cutters, capsule cutters, as you would name, these are cutters which would cut through specific tissues wherein you want to remove cut the anchorage before delivering a fragment out. Hooks are used for teasing the fragment and just to move. There are flexible hooks also available which just deflects. But these are all instruments which are dangerous, and the epidural space, if you create a new bleeding, your vision will be hampered. So you should not go on to these instruments before you have good handoff on the basic procedures you have done. Scoops to remove little bit of hard annulus or calcified fragments, say articulated scoops are also available. Endo-osteotomes are available. I do calcified discs, so you remove with this. You do foraminoplasty, so you have to use this, but not for the initial classic cheesy cases. You don't need it. Malleable retractors are there which can be used. This is a joy mesh system. This is again a wonderful thing which just deflects and helps you. These are dissectors which does soft dissection for you fixed tissues which is there. Carrison punches, very small. It's 3.5, 4 mm. The things which it holds or cuts are very, very precise and small. So it doesn't hold and it doesn't catch hold and remove like or peel off by, what we get in from a posterior surgery. RF is something which can be used and which is needed for, say, vaporizing tissue or ebolating tissue or controlling bleeding. And in fact, the tip of this RF, the radio frequency, is a dissector in itself also. So you can use any of the systems of the RFs which is available. And and I am honestly telling you, I haven't used a heat inside the disc for the first 3 years when I started. So it was not needed. So you can use, you should use when you need to for the epidural bleeds, and it is more for a dissection purpose and identifying things rather than actually using too much of heat inside the disc. There is no role of big heat inside the disc. So, and the same time, if you want to invest into, you can use into say Eloquence or any of the other companies which are coming with RF systems. But even a simple bipolar also does the same job. You can put in this the RF probes which is there, and this can be connected to any of the simple cauteries which you have, and it does the job basic for you. You need not spend huge amounts of money for this. These probes come at 20,000-25,000 rupees, and they are disposable, though can be used frequently. And this is what I was talking about, why it is used as a dissector, because it can deflect. So this is the tip of the RF probe which is there. Now this is another thing which is there, which I was just talking about, the foraminoplasty set. So this is the foraminoplasty set. This is a Tom Shady Maxmore foraminoplasty set for a blinded expanded expansion of the Cambin's triangle for outside in techniques for L5S1 cases. But this was not needed by me also for the first 4-5 years. I have been using a DCS reamer in the initial cases because I didn't have any access to these reamers at that point of time. Now this is available, even Indian makes, say 60,000, 70,000 you can buy also. But I didn't have any access. I was able to do a transiliac with this. Whenever I needed a foraminoplasty, I have used this. So it is possible, and not to increase your inventory load and the cost onto your shoulders. A endo burr, I have this Novak burr which I use for almost all surgeries whenever calcified things are to be done. This has got various tips which is the front tip, the side tips, the diamond and the soft ones, and this is the deflectable one. This deflectable one is wonderful, but it doesn't last long. I bought only once. You cannot add to the cost of say 1 lakh or 1.5 lakh for a burr tape, and then you lose that burr tape and you cannot charge from the patient. So this is, though a tape, wonderful, but it cannot be used frequent, and whatever is malleable is going to be breaking. Whatever is articulating is going to be breaking. So you have to think about the sturdiness of whatever you are using, and transforaminal burr is used in limited number of cases. Recorder you need if you want to present, so you need recorder. So I have a Sony DVR which is needed. This is an old version, you may buy on a new one, not needed. There are small systems which is there. Even a Wolf endoscope, Wolf camera has got intermittent recording system with their USB, so that is possible. So that allows even recording, so with the camera itself. So that is a very good system to invest to. Laser again is a fancy way of doing things. I use laser only in those patients wherein the patient has demanded that laser, sir laser ka kuch karke laser wala karenge, then only. Because they tip this probe, this cost you 65 to 75,000 rupees. This may last for one case or maybe 3 cases. At the same time, this inventory is huge costly. It is not needed. It is again heat. It has got very precise action. It is used for soft tissue ablation. It can also ablate bone. It takes time. At the same time, if you miss the target, you are around nerves, you can induce dysesthesias like anything. So that's why you have to be very careful. If you are lucky to have it in your institute, you can use it, but not as a regular, you need it also. So this is the other thing which is there. Now, the other concern about is that because this is an endoscopic surgery, you may have more of radiation exposures. You may be either protecting yourself with multiple gears, or you may have to accept, even with the best of the studies which has been published, if you do with protective gear surgeries, you can do 300 to 500 surgeries with this. These are publications which say with the routine the fluoroscopy. So you should not be worried about it. But at the same time, like we have OARM, we have navigation. I have explored it for the fun of it. It's not needed. Now a lot of systems are coming who are into the endoscopic systems. They are jumping onto the fixation systems also, because these companies like Joymax, Maxmore, Wolf, everybody is concentrating on development of navigation, because that can be used for both purposes, being the endoscopic surgery as well for the navigated screw and implantation purpose also. So this is going to be definitely going to be penetrating into our spine practice navigation. We have to see how it goes. But again, it is a fancy thing. I never did it
Ajay,
can you conclude? We are just running slightly time.
So basic tool what you need is this much what I am showing you. Here is the endoscope what you have to have. You have the dilator, you have the needle, you have the hammer, you have a 3.5 and 2.5 grasper, an annulus cutter, and endo tower. This is all what you need in a transforaminal set. For a UB set, this is even cheaper. That comes in 3 to 5 lakh rupees, and it is basically a 0-degree scope which you want to have. And most of the instruments are sturdy and it's last long. For interlaminar stenosis set, it is again even more lesser number of instruments which only few, one Gasper would do, a dilator which is there, and you can have this Carrison punch which would help. But for posterior interlaminar surgeries or UB, you need to have a burr which is must. Without burr, you may not be able to do many of the surgeries. So you need burr for interlaminar stenoscopic surgeries, and that is must. That is not must in case of transforaminal surgeries. And coming to the learning curve part, the learning curve, what is said in the literature is that this is one of the studies in the 2008 wherein a 51 patients was retrospectively reviewed for the time duration what it took to learn. And by 15 to 17 cases of a transforaminal surgery, people started improving on their time. This was a Russian paper which is there, which is a recent paper, and that says that the interlaminar group would take 20 surgeries to just have a hang of it and reduce the timings of the surgery. But transforaminal, you mature more early. That is by even a 7th surgery, you are able to. This was by our mentor, teacher, Anthony Young, who at some time in 2007, around with a study of 144, said that you need 72 cases to master to achieve a 90% good result. This was too huge a number what he was saying. And the same senior teacher has now come up with a paper this year, and he has just trained 2 surgeons who were already into conventional surgeries for good number of 12 to 28 years. And they first made them do transforaminal and blocks. And by 15 surgeries, they both were comfortable to do the transforaminal surgeries. So if you have proctors, mentors, you can learn it faster. That is the thing. And one of the negative things which I've heard from many people's mouth is that endoscopy transforaminal has got a steep learning curve, but you are interpreting it wrong. Statistics means a steeper learning curve is easier to learn. This is your learning curve. Steep doesn't mean that you don't learn it fast. Steep means that you learn it fast. Whereas all interlaminar surgeries will take more time for you to learn, and they are also associated with earlier complications more than the transforaminal. This is what the literature even says. So you can be a modern marathoner with all the gadgets and run around, and you can just start it with the basic set and start doing it. That is what is required. So do you need to have all those stuff, and need to do it all alone? That is the most important question. When you try to do everything by yourself, you will not be mastering all these things. It's very difficult for you to jump to a new thing, learn it, and then reproduce the results. And then what you start saying is that that technique is bad. Rajshekharan sir in one of his presentations had one time, don't try to acquire more skills.
Ajay, please conclude. We are 30 minutes. Your lecture.
Yeah. So Rajshekharan sir once said that by 40-45 years, you should acquire what you have done, and you should continue doing that. So what is needed is team building. So if somebody is doing a transforaminal surgery, other one could do an interlaminar surgery. You can go and take the credit of the open surgeon who has matured so much in the open surgery. So don't question those techniques, because they give excellent result today and proven results. So it is not going to go away. And at the same time, MIS fixations, everything are going to be there. So what is the need is to be more into team and do all techniques combined up and change our mindset to pick it up. Thank you.
Thank you, Ajay. Very elaborate, nice lecture that I think we just covered most of the things, how to have the basic set and then how to advance yourself with the further equipments, because you can put in a lot of equipments in endoscopy as much as you want, and the cost is going to rise also. So just one question from any of the panelists to Ajay, and then we conclude the session. Yes, Karthik.
If somebody wants to start a UBE, would you recommend using a 0-degree scope for a beginner or a 30-degree scope? Because there's some diverse views on this.
These both views are okay. Is the thing that once you start using, the biggest thing which we have to understand is that whatever you procure, whether it is a 0 or a 30, you will end up finding your ways to explore. A 0-degree scope is what I am using, and it works wonder. Whosoever is working, they actually find their ways to use the instrument. It is not about the scopes. Both are equally good. There are different teachers who have taught it differently, but 0, 30, both are good. I am using a 0-degree.
Okay.
Okay. Anybody wants to ask any questions from the panel, or any questions from the audience who are watching it? Arvind?
Yeah, I'm just in touch with Neeraj to find out if there are any questions. Neeraj?
Yes.
Any questions from the viewers?
No. It's too early, I think.
Well understood. We were too early.
Facebook पे एक दो comment थे, but there are no questions.
Okay, so I think we had a very nice session with a very good articles from the degenerative listhesis and the cortical screws, and we had a very three nice cases. All the three had some message to be given, and at the end, a good lecture by Ajay, comprehensive, which covered all the things for the newer surgeons who want to start up the endoscopy, and very good tips that he has given. And I would conclude and give it over to Arvind for the last remarks.
I thank all the faculty as well as the viewers. Not by design, but on its own, it is shaped out to be an interesting webinar, which by default includes the youngsters as well as the veterans. So there is a good combination. It was not by design; it just happened so that the case presenters and the article presenters are the young warriors, and we the veterans are giving talks on how to start scopy. I think it is start minimal access. So it's a good combo, and we'll choose interesting topics. And even we have our group. The society has a group. If someone is interested, you give us your feedback as to what you want to learn and what topics need to be covered. I think we have covered enough on endoscopy. Maybe next few months we will have talks on microscopic techniques and destendo, more on fixation, navigation, etc. So next webinar will be on 9th of August, again a Sunday morning, and the reason we have it early in the morning is it is not just one of the things of the day. You basically have to specially get up and give importance to this webinar. That is the reason we have it early in the morning, and we were done with it by 9:30. So I thank thank the Intas company for supporting us in this educational endeavor, and also OrthoTV Neeraj Bijlani for streaming this in all the available platforms that are possible. Thank you.
Thank you, everyone.
Very much, and bye-bye.
Have a nice day.